Hello, everyone, and welcome to an exciting session with MedSynapse. Tonight, we'll dive into fascinating world of Guillain-Barré Syndrome. This is not just another webinar; it's a chance to explore groundbreaking advancement and visionary insights that are shaping the future of healthcare. Today, we are honored to host a distinguished expert in the field of healthcare and innovation, Dr. Muttu Kumar Vellaichamy. He is the founder and managing partner of KB Capital, a firm renowned for its strategic investment in healthcare and life sciences. With over 30 plus years of experience as a healthcare consultant, he is currently practicing in Texas and Florida and expanding into multiple states. Today, Dr. Kumar will share his insights on the latest development in GBS. Without further ado, let's welcome Dr. Kumar for the insights.
Thank you so much for the kind introduction. Thank you, Dr. Bart. Today we are going to talk about Guillain-Barré syndrome. The first Guillain-Barré syndrome, as you all know, it's a rare but potentially life-threatening immune-mediated polyradiculoneuropathy. It causes acute flaccid paralysis both in children and adults. It is a post-infectious disorder triggered by bacterial or viral infection, most commonly by Campylobacter jejuni, especially in Asia and China. GBS typically presents with paresthesia, pain, or weakness of the limbs that rapidly progresses in days. The progress usually ascending in character. Around 20% of the patients may develop weakness in all four limbs and respiratory failure requiring mechanical ventilation. It is the most common cause of acute flaccid paralysis worldwide. The global incidence is 1 to 2 per 100,000 persons. In low middle income countries, including Africa and Asian continent, no epidemiologic data are available, so the incidence may be skewed in the lower side. The males are affected about 1.5 times more frequently than females. The risk of GBS steadily increases by 20% for every 10-year increase in age. The incidence of GBS fluctuates seasonally, probably related to infection that can trigger the disease. As you can see here, most of the data came from high income countries. Very few data came from low income countries. As a result, the incidence of 1 to 2 per 100,000 may not be very accurate. The mortality of GBS is varies between 2 to 10%. Again, it is geography dependent. In Europe and North America, the mortality is 2 to 7%. In Bangladesh, it is 14 to 17%. In Egypt, 16%. The disparities you see in different income countries, most likely because of non availability of treatment or specialized care. For example, in Bangladesh, 10 to 12% of the patients can only afford IVIG or plasma exchange. The risk factors for mortality: high age, severe weakness at an early stage of disease, late presentation, and mechanical ventilation. GBS always associated with preceding events like infection with Campylobacter jejuni, Mycoplasma, cytomegalovirus, Epstein-Barr virus, hepatitis, and Zika. Campylobacter jejuni being the most common preceding infection. It happens about 30% of patients with GBS. The second most common preceding infection is Mycoplasma pneumonia. And of course, dengue, chikungunya, varicella zoster, HIV all can cause. In addition to infections, vaccinations have been incriminated, malignancy, trauma, surgery, especially those involved with bones and digestive organs, also linked to GBS. When there is an outbreak of infectious disease that has happened, Campylobacter outbreak that happened in China in 2007, in Mexico in 2011, Peru 2018 and 23, there is increased incidence of GBS. Zika virus epidemic, when it affected South America between 15 and 16, there was a cluster of cases reported from South America as well. The recent outbreak of COVID purportedly linked to increased incidence of GBS worldwide. The GBS can be broken down into two major classifications. One that causes demyelination, another one is that involve axonal injury. The demyelinating type is often called AADP, acute inflammatory demyelinating polyneuropathy, wherein the deposition of activated complement macrophages and activated T cells and Schwann cells. These inflammatory cell deposition provide evidence of an antibody-mediated immune attack. I will explain to you in a little bit detail in forthcoming slides. Next one is acute motor axonal neuropathy, where there is an activated complement deposits a nodal and internodal axonema. The AMN, which is motor neuropathy, can have antibodies specific to gangliosides like GM1 and GD1A. The molecular mimicry is a theory for the mechanism of inducing autoimmunity. In C. jejuni, Campylobacter jejuni, lipopolysaccharide, which is in the cell wall, has similarities to the structure of gangliosides, which is GM1 and GD1A. So when the body amount antibody response to Campylobacter jejuni, the same antibodies hit those myelin sheets as well as this the gangliosides in the neurons. So the pathogenic subtypes are grouped into three. One is demyelinating, second one is axonal, third is combination of both demyelination with axonal involvement. Acute inflammatory demyelinating polyradicular neuropathy, which is simply demyelinating lesion. Acute motor axonal neuropathy, which is axonal, which most commonly seen in India and China and Asian countries. Acute motor and sensory axonal neuropathy also can be seen when there is a motor and sensory component together. Recovery is different among these three entities: motor axonal neuropathy, motor and sensory axonal neuropathy, and inflammatory polyneuropathy. So, in AADP, remyelination is necessary for restoration of the function. On the other hand, in motor axonal neuropathy and motor sensory axonal neuropathy, the severity of the damage from antibody deposition to the axon influences the timing and the degree of recovery. They tend to have longer time to recovery and less recovery than demyelinating forms. Since Campylobacter causes AMAN and AMSAN, so they have severe illness and takes longer time for them to recovery. The predominantly what we see in United States and North Europe, AADP, the recovery is much better than AMN and EMSAN. This diagram explains how the antibody response to the Campylobacter injures the nerve cells. As you can see, Campylobacter jejuni, the immune cells react to Campylobacter jejuni infection and produces antibody. It's not only attacks the Campylobacter jejuni to eliminate, the same antibody can attack the neurons because the gangliosides mimic like lipo-oligosaccharide of the bacterial cell wall. Then it activates complement. Then it forms the membrane attack complex that resulting in myelin injury and subsequently calcium influx causes axonal injury. Then there are specific antibodies that formed, especially GM1 and GD1A, which is more common in Campylobacter jejuni infections, that affects the nerve terminal. As a result, it causes muscle weakness and resulting in motor and axonal neuropathy. Then other specific form of antibody develops, meaning GQ1B, that specifically affects the cranial nerves 3, 4, and 6, and also type 1A sensory fibers. As a result, it can cause ophthalmoparasis and ataxia, that is so called Miller-Fisher syndrome results. The combination of ophthalmoparasis, ataxia, and areflexia is called Miller-Fisher syndrome. Regardless of the primary mechanism, the final outcome in GBS is peripheral nerve damage. That includes endoperineural and subperineural edema, inflammatory infiltrates, segmental demyelination, and axonal damage. The motor and sensory form is the most common form, most frequent in Europe and in North America. The motor GBS, the weakness without sensory symptoms or signs, more frequent in some countries in Asia. The lots of studies have been done in Bangladesh. As a result, the reference usually Bangladesh. Sometimes GBS can affect certain parts of the body. They are called regional variants. The regional variants can be its localized to one part of the body. It could be pharyngeal, cervical, brachial GBS. Sometimes it can cause bilateral facial weakness with limb paresthesias. Sometimes it can confine to the lower limbs, so called paraparetic variant. It may evolve into tetraparesis. Even though there are GBS variants can affect certain parts of the body, sometimes overlap can happen. In fact, most of the time overlap happens, then they develop or evolve into the most common variety of motor sensory GBS. The most recognized form of another variant is MFS, Miller-Fisher syndrome, that comprises of ophthalmoplegia, ataxia, and ereflexia. Even this MFS has three variants. The fairly large proportion of MFS have features of motor and sensory GBS. This is called GBS MFS overlap syndrome. It can be incomplete. You may not have to have all the three components to it. That is called incomplete MFS. And the other known variant is called Bickerstaff brainstem encephalitis. This is the only variant that has impairment of consciousness. None other variants have impairment of consciousness. This Bickerstaff brainstem encephalitis, you will have ophthalmoplegia, ataxia, and pyramidal tract signs and impaired consciousness. When you do a brain MRI scan, you will see white matter changes. Other disorder one should keep in mind is called acute onset chronic inflammatory demyelinating polyradicular neuropathy. Even though CADP is a different disease, when it presents acutely, it mimics exactly like GBS. The 5% of ACADP diagnosed with GBS. Once it lasts longer, then it's categorized into chronic inflammatory demyelinating polyradicular neuropathy. But one should not really worry about the diagnosis when it present. You treat like, even though we talked about AADP, AMN, AMS, motor sensory axonal neuropathy, all of them we treat in the same way. Few of these patients do not respond to IVIG and plasma exchange. They have a specific antibodies against nodal and paranodal antigens like neurophysin 155, Casper1, and Cantin1. So the identifying antibodies will definitely make this disease diagnosis more likely than AADP, which is the most common variety of GBS. So, as we mentioned earlier, there are three kinds: demyelinating, axonal demyelination with axonal involvement. Most of the time, they overlap. This is the most common acute inflammatory demyelinating polyradicular neuropathy, and other uncommon in Europe and United States is acute motor axonal neuropathy and acute motor and sensory axonal neuropathy. They are common in Asia, in India, Bangladesh, and China. The other important things you come across is in GBS is dysautonomia. 25% of children and adults have dysautonomia. Most of the time, it implies the severity of the disease. What is dysautonomia means? Instability in blood pressure, heart rate, pupillary dysfunction, and bowel bladder dysfunction. Exaggerated drug responses, GA dysfunction, cardiac arrhythmias, and hypersecretion can also occur. So, the most important thing as far as diagnostic and therapeutic is instability of blood pressure. Blood pressure can shoot up into 160, 170. So, we have to resort to treat the blood pressure. But you cannot give long lasting blood pressure medication because it can the blood pressure can drop precipitously. So that needs to be treated when it exceeds higher, and needs to be followed if it falls lower, so on and so forth. Now, what are the difference between pediatric and adult GBS? There are small little differences because of the age than anything else. Number one, examination will become a problem in pediatric age group because they may not cooperate, especially when they are less than 6 years old. The pain can be a prominent feature. In fact, pain is present in GBS in 50% of the patients. But good thing is in pediatric, the outlook is improved. They get better, much better than adults. And again, respiratory compromise only 15% in pediatrics when compared to adults, which is 30%. And less than 6 years of the patients, whether it is because of inability, muscular weakness, or pain, or some other reason, they refuse to walk. So that is the most common presentation in pediatrics. In adults, it is much more severe. Respiratory compromise is 30%, two times that of pediatrics. The pain is less common feature. The GBS has three phases in its course. Number one, you will have a precedent infection. It could be viral infection or Campylobacter jejuni or sometimes malignancy, trauma, or surgery. Then followed by ascending paralysis or ascending weakness with paresthesia. That usually reaches a nadir. It gets worst at 2 weeks of age, and it does not exceed more than 4 weeks. Almost 85 to 90% of the patients develop maximum amount of weakness at 2 weeks. Almost all, 97 to 99.8%, gets the worst neurological progress by 4 weeks. If anything progresses beyond 4 weeks, one should think in terms of other diseases like CADP, chronic inflammatory demyelinating polyneuropathy, or nodal neuropathy, so on and so forth. Then the plateau phase ensues. That can last from 1 month, which is 4 weeks, to all the way up to 6 months. Then afterwards, the recovery phase ensues. It can last up to 2 years and beyond. The clinical hallmark of motor sensory and motor forms of GBS is progressive flaccid limb paralysis and areflexia. Sensory loss is present in predominant motor sensory form but absent in motor form. The most severely affected patients develop respiratory failure and autonomic dysfunction. These are the two elements that causes death among patients with GBS. So one have to monitor and treat appropriately. The hallmark of MFS, which is Miller-Fisher syndrome, it is the most recognizable variant of GBS, triad of ophthalmoplegia, ataxia, and areflexia. There are eight variants have been described. I'll go one by one. Motor sensory, it is the most common form. These patients present with ascending muscular weakness along with sensory impairment. Second category, which is about 25%, its motor form oftentimes following Campylobacter jejuni infection. They have a pure motor weakness without any sensory impairment. Paraparetic, it is confined to the lower limbs, but as we say, it can evolve into upper limbs causing quadriparesis. So only the time can tell. Earlier identification, earlier therapy can halt the progress. Other regional variant is pharyngeal cervical brachial, which confined to neck, upper limbs, and upper thorax. Sometimes it can present as with bilateral facial palsy with paresthesias. So whenever you have a bilateral facial palsy patient present, do sensory examination and do spinal tap and nerve conduction studies to confirm the diagnosis. Sensory variety is pure sensory variety is less than 1% rare, but when you have paresthesia in all the four limbs, that is not, they don't have any other disorder um, to the etiology basis, you couldn't find anything, most likely is GBS, or that patients you need to do spinal tap studies and nerve conduction studies to confirm the diagnosis. Miller-Fisher syndrome, as you mentioned earlier, the triad of ophthalmoplegia, ataxia, and areflexia. The other variant of Miller-Fisher syndrome is Bickerstaff brainstem encephalitis, where is you will see have impaired consciousness along with ophthalmoplegia, ataxia, and areflexia. This table shows motor sensory is the most common, almost 30 to 85% of the patients. Based on the geography, the incidence varies. And the motor sensory form, even though it is more common, there is no antibody is linked to motor sensory. There are lots of them have been studied, nothing is linked as we see in other forms. In pure motor forms, you will have GM1 and GD1A antibody, and they have pure motor form. There is no sensory, no cranial neuropathy. Cranial neuropathy can be there, and there is no central nervous system involvement. Paraparetic, that involves just lower limbs, and again there is no antibody attached to it. And pharyngeal cervical brachial, they have a specific antibody attached to it called GT1A. They have less than 5% proximal upper limbs are involved, and most important is bulbar muscles involved. So these patients needs to be intubated early on. Another category is bilateral facial palsy with paresthesias, where the bilateral facial palsy with paresthesia and distal limbs. And the sensory variant is very rare, affecting less than 1%. They have a specific antibody associated called GD1B. Miller-Fisher syndrome accounts for 25%. Oftentimes, most of the patients will have overlap. It will start with the Miller-Fisher syndrome. Again, it is rare. It is very uncommon in United States, North America, and Europe, but it's more common in Asia. And oftentimes they develop overlap syndromes. That means they will develop motor and sensory signs and symptoms later on. They have a specific antibody associated with GQ1B, GT1A. Bickerstaff brainstem encephalitis, one step ahead, they have altered consciousness and hyperreflexia. This is the only condition has hyperreflexia. Everything else has areflexia. Again, Bickerstaff brainstem encephalitis, when you suspect Of course, you get MRI, spinal tap, nerve conduction studies, and most importantly, the antibodies GQ1B and GT1A. Outcome measures. This particular slide is very important. Based on GBS disability score, the treatment is recommended. So I want to go one by one. It is published in Lancet 2007 and has been studied well since then. In healthy state, GBS DS score is 0. GBS DS 1 means minor symptoms capable of running. GBS DS 2 able to walk but unable to run. Able to walk without assistance, that is 2. 3 able to walk but with help. 4 bedridden. 5 required assisted ventilation. 6 dead. These are all the guidelines, diagnostic criteria laid out by European Association of Neurology and Peripheral Nerve Society guidelines 2003-23. I want to go one by one. One is, what are the required features of making a diagnosis of GBS? Progressive weakness of arms and legs, absent or decreased tendon reflexes in affected limbs, and progressive worsening in less than 4 weeks. If there is a progressive worsening more than 4 weeks, not most likely it is not GBS. GBS often associated with other supportive features like relative symmetry. You got to have bilaterality, relatively mild or absent sensory symptoms and signs, cranial nerve involvement, especially bilateral facial palsy, autonomic dysfunction, respiratory insufficiency, often from muscle weakness, except the bulbar weakness variant, pain, muscular or radicular in back and limb. Recent history of infection, usually within the last 6 weeks. Every patient with GBS should have spinal tap done. It should show increased protein and normal white cell count. Serology, not necessary in motor sensory, the most common variety, but in other varieties that will clinch or support the diagnosis. For example, in Miller-Fisher syndrome, identifying GQ1B antibodies definitely will help the diagnosis. No conduction studies needs to be done. It should be consistent with peripheral neuropathy, but it can be normal in early disease. After 4 weeks, definitely it should be sensitive enough to detect all GBS patients. Earlier than that, it is kind of wishy-washy. Definitely within the first week, it may be normal. The finding inconsistent with GBS when you should think maybe it's not GBS. When there is an asymmetry and marked and persistent. Severe respiratory dysfunction at onset. That means severe respiratory dysfunction that happens within 24 hours. Most likely it is not GBS. Predominant sensory signs at the onset of mild weakness. So sensory symptoms are predominant while the weakness is less. Fever at onset. Sensory level or extensor plantar responses. Hyperreflexia. The only exception is the bigger staph, brainstem encephalitis, bladder and bowel dysfunction, abdominal pain or vomiting, nystagmus, alteration of consciousness, except in bigger staph, brainstem encephalitis, abnormal routine blood tests, CS of more than 50 pretty much excludes the possibility of GBS. When you're entertaining the diagnosis of Guillain-Barré syndrome, one should exclude other possibilities. It's very crowded. I'm going to make it smaller pieces. Encephalitis, it's easy to distinguish. They will have drowsiness. Most importantly, they will have pleocytosis in CSF. In MRI, brain will have hypertense lesions, slowing with or without epileptic on discharges. Brain stroke, very acute, and MRI will confirm the diagnosis. Spinal cord lesions such as transverse myelitis, you will have sensory levels and brisk reflexes. GBS have areflexia. MRI spine will have hyperintense lesion. Malignant infiltration, they will have pleocytosis, malignant pleocytosis, and MRI spine will have enhancing lesions. Anti-Hansel diseases like intraviral illness, polio, all will have fever, pleocytosis, and microbiology will be positive. Neuralgic amyotrophy, there will be asymmetry. The findings limited to the nerves affected. In GBS, there is a polyneuropathy. MRI brachial plexus will have nerve enhancement. The nerve conduction studies abnormalities restricted to the affected nerves. CMV HIV radiculitis, again, CSO pleocytosis, titers for HIV and CMV, and nerve conduction studies. Among peripheral nerves, I will come to CADP later. Let me kind of take all the other ones. Metabolic and electrolyte imbalances, you will have a precipitating factors, biochemistry of low serum levels of specific electrolytes. Critical illness, prolonged illness or ventilation. Axonal neuropathy with or without myopathic features, most of the time the history will distinguish from GBS to other critical illness polyneuropathy. Diphtheria, it's uncommon but still can happen. Laryngeal infection, the microbiology can isolate Corynebacterium diphtheria. And these patients can have demyelinating neuropathy and albumin cytological dissociation. The differentiating features would be throat infection and isolation of the bacteria. Thiamine deficiency, they will have precipitating factors like hyperemesis gravidarum, alcoholism, nutrition deficiency, and other features of Wernicke's encephalopathy. You have abnormal thiamine levels in erythrocyte transketolase activity abnormal. Lyme disease, history of exposure, and the characteristic rash, erythema migrans in Lyme, and microbiology and serum titers will distinguish it from GBS. Porphyria, family history, concomitant psychiatric symptoms and abdominal pain, raised urinary porphyrin and axonal neuropathy. Among the peripheral nerves, only the CADP, when it present acutely, it's difficult to distinguish from GBS. The only thing is, if the weakness lasts more than 4 weeks, that automatically puts into CADP. Or when you have MRI, which shows widespread enlargement nerve roots, that will distinguish. And non response to IVIG and plasma exchange, again, raise a concern for CADP. Neuromuscular junction and muscle, it is easy to distinguish. Myasthenia gravis will have fatigable weakness, relapsing and remitting, and other antibodies can be detected. Botulism, rapid progression, pupillary abnormalities usually affect children less than 1 year of age. It causes descending paralysis as opposed to ascending paralysis as happened with GBS. Microbiology can detect botulinum toxin, and nerve conduction studies will show incremental rise in rapid repetitive nerve stimulation. Lambert-Eaton syndrome, proximal weakness, depressed tendon reflexes and autonomic changes, and antibodies against voltage-gated calcium channels. Muscles, proximal weakness, normal reflexes, and raised creatine kinase that distinguish from GBS. Well, how to treat now? The two components in the treatment of GBS, as I said, the most common cause of death is non-availability of ICU to take care of the respiratory insufficiency and autonomic dysfunction. That is the most important component that happens early on in the disease process. Second, the specific treatment, IVIG and plasma exchange. Let's talk about prediction of the need for ICU admission first. GBS can present rapidly progressive weakness, lead to respiratory insufficiency in hours to days, but it will not happen within 24 hours. So you need not to have to do like in other diseases. Elective transfer to ICU may result in early recognition of need for ventilatory support and intubation. And assessing the risk for respiratory failure early in course of GBS. The tool most of the people use is modified eGRIS that requires four clinical factors: rapid disease progression, bulbar palsy, weaker neck flexion, and bilateral hip flexion. So regularly assessing the risk factors very important because things can change every day, every hour. So rapid progression of limb weakness during hospital admission, that means when the GBS DS grade of 4, neck flexion, facial bulbar weakness, especially inability to cough, autonomic instability, fluctuation BP and heart rate, automatically needs to be in ICU. So regular assessment of forced vital capacity, single breath count when available, maximum inspiratory pressure, maximum expiratory pressure. We routinely do MIP and MEPs. When there is an elevated liver function test or infection with associated herpes simplex and CMV or electrodiagnostic feature demyelination, there is a high likelihood they will run severe course. They need to be in ICU. The forced vital capacity should be checked every 4 hours. At least needs to be done 3 to 6 times a day. When there is a fall of forced vital capacity more than 30% from the predicted baseline should alert concern. When there is fall more than 30% in 24 hours needs transfer to ICU. More than 50% decline from the baseline need for ventilation. The elective ventilation needs to be done when the forced vital capacity is less than 20 ml per kilo, and mechanical ventilation inevitable when the forced vital capacity is less than 10 ml per kilo. The maximum expiratory pressure of less than 30 or maximum inspiratory pressure of less than 40 indicates need for elective ventilation. It's very important you anticipate and act preemptively. Even after discharge from ICU, frequent monitoring for late respiratory cardiovascular complications are must because these are the two killers of this disease: respiratory and cardiovascular complications. The immune treatment for GBS, as we mentioned earlier, plasma exchange and intravenous immunoglobulin. Even though this guideline discuss corticosteroids and other treatments, pretty much they are not used, only these two. We are going to talk about when to use and how to use. Plasma exchange. Plasma exchange should be started as soon as possible in GBS patients when there is GBS DS grade 3 or more. When they cannot walk without help, they need to be started on plasma exchange. 5 exchanges over 1 to 2 weeks, with a total exchanged volume of 12 to 15 liters in patients who are severely disabled. When they have a GBS DS grade 2, 2 exchanges in the first 2 weeks is recommended. When you have a GBS DS grade 2 still evolving. When there are certain patients who are still ambulatory, they can walk, but they are deteriorating fast, requiring they may need requiring ventilator support, have a swallowing difficulty, and other poor prognostic factors or autonomic dysfunction. They need to have 4 to 5 exchanges over 1 to 2 weeks. So whenever there is a deterioration, 3 and above automatically gets plasma exchanges. 2, when you suspect it will worsen, go ahead and do it. The only two categories no need to have plasma exchange. One, GBS DS grade 1, that stable disease, that means they can walk independently and run. GBS DS grade 2 walk independently and they are stable. Second one is immunoglobulin. Because I say second doesn't mean that it's secondary. Both plasma exchange and the IV immunoglobulin are efficient in treating GBS. They have equal efficiency. IVIG needs to be given as soon as possible in patient GBS DS grade 3 or more. The guidelines recommend a standard course of zero point 0.4 gram per kilogram per day for 5 days. There are courses for 3 days, 6 days, and 2 days. The studies have shown shorten the course causes reoccurrence of the disease. So the 2023 guidelines confined to zero point 0.4 gram per kilogram per day for 5 days. Okay, when to treat? As I said, GBS DS grade 3 and above, automatically they need to get zero point 0.4 gram per kilogram per day for 5 days. Those with GBS DS grade 2 within 4 weeks, but have a fast rate of deterioration and risk of requiring ventilatory support, swallowing difficulties, autonomic disturbances. Those patients also need to be treated IVIG for 5 days. And the other grade, GBS DS grade, slowly deteriorating disease, can be considered to be given IVIG or plasma exchange. IVIG is not advised in GBS DS grade 1 and GBS DS grade 2, but stable. Can we give IVIG immediately after plasma exchange or do plasma exchange after IVIG? There is no indication to do both on the same patients because it increases the side effects without having any beneficial effect. So, as a result, 2023 guidelines not recommend to doing both the treatment on the same patient. Next is usage of corticosteroids. The guidelines strongly recommends against oral corticosteroids, even though it is inexpensive, but there is no evidence to support the use of corticosteroids. In fact, there is even can cause harm in GBS patients, so the corticosteroids are completely out. Immunoadsorption and followed by IVIG. What is immunoadsorption? It's technique to remove pathogenic antibodies. The current guidelines do not recommend immunoadsorption for the treatment of GBS. As you all know, the complement is involved in membrane activating complex, membrane attack complex. Even though it was beneficial in animal model, there is no evidence base in humans. As a result, the current guidelines recommends against using euclizumab. It also recommends against other medications like alemtuzumab, brain-derived neurotrophic factor, CSF filtration, cyclophosphamide, interferon, and mycophenolate mofetil, triptylgerium, and all this also recommends against. And also does not recommend neuromuscular electric stimulation within 2 weeks. And also against 3,4 diaminopeptidine to improve the muscle strength. So only IVIG and plasma exchange. This is summarizes in the table. When the GBS is more than 3, either give 4 to 5 exchanges in 1 to 2 weeks or IVIG over 5 days. When the GBS DS2 recommended 2 exchanges in 1 week, if you do a plasma exchange, if you do IVIG, same like GBS DS more than 3 or above. These two categories, GBS DS2 and GBS DS1, they do not need plasma exchange or IVIG. What happens if the patient had a treatment related fluctuation. What does that mean? It's defined as initial recovery or stabilization after treatment, either with plasma exchange or IVIG, then had a secondary deterioration. Those patients, again, reinitiating plasma exchange and redoing IVIG. If there was no response to plasma exchange or IVIG, there is no need to give a second dose because second dose doesn't change the outcome. Other important things apart from immunotherapy for Guillain-Barré syndrome, physiotherapy, speech, swallowing, and occupation therapy. All these needs to be evaluated and started when the patient is in the hospital. In addition, these patients do need psycho-emotional aspects evaluated and treat accordingly. As you can see, there is a multiple psychological issues happen in patients with GBS. They can have anxiety, in fact, 82%, in depression, stress, reactive psychosis, sleep disturbances, fatigue are the most common psychosocial complication of GBS, and changes in daily activity, changes in work, and sexual problems. All needs to be evaluated and treated accordingly, along with immunotherapy. As I said, the pain is the most important component, either initially and also later. The first choice of to treat the neuropathic pain in GBS is gabapentinoids, either gabapentin or pregabalin or TCA. After exclusion of if there is no underlying erythema, one can use tricyclic antidepressant. The second choice is carbamazepine or serotonin noradrenaline reuptake inhibitors like duloxetine and venlafaxine. The usage of yoga, meditation to improve the emotional well being, the current guidelines do not recommend for or against. The fatigue is the other most common psychosocial issue with GBS, affecting 38 to 86%. That needs to be treated either pharmacologically or non pharmacological strategies like graded exercise program, cognitive behavioral therapy, and physical fatigue management strategies needs to be done to improve the fatigue that happens with GBS. Even though the guidelines do not advise for or against exercise training, since exercise cannot harm the patients, most of the practitioners do graded exercises in these patients to improve the muscle strength and also overall feeling better. But there are certain prognostic factors that determines inability to walk or prolonged course in patients with GBS, especially when it happens in the older age. When there is a preceding diarrhea or gastroenteritis, meaning they had the acute motor axonal neuropathy, or higher GBS disability scores at admission, like 4 or 5. Those patients have prolonged course in the recovery period. This concludes the presentation on Guillain-Barré syndrome.
Thank you so much, Dr. Muthu. It was a lovely presentation on GBS, and we have few more audience questions which we like to discuss and want your opinion on it. So the first question is, in your experience, what is the most effective strategy for preventing complication in GBS patients?
Excellent. Thank you for asking. The most effective strategy for preventing is just watch for respiratory insufficiency and watch for autonomic dysfunction and make the diagnosis quicker and treat with IVIG. We tend to use IVIG because it is easily available, easy to be given, and you do not need a catheter placement for plasma exchange. So that can be quicker.
Okay, and followed by second question, what is your preferred approach when selecting between IVIG and plasmapheresis in GBS treatment?
In children, IVIG number one. In adults,
Mhm.
again IVIG one number one because a couple of reasons. Number one, the complication with plasmapheresis is you need to have an instrument, you need to have a person to run the exchange that also 2 to 4 hours every day for 5 days. That
Okay.
means cath related complications. And also, when you do a plasma exchange or plasmapheresis, what happens? It causes hemodynamic up and down. These patients already have autonomic dysfunction that is going to further affect. uh, so plasma exchange being spoken in GBS because that was the first treatment came up, but because of the availability of IVIG and you need just IV line, you need to run over 4 hours. That is much more less complicated. Less complications come out of IVIG unless otherwise they have IgA deficiency or they have allergic reactions to IVIG. Except those two conditions, I think IVIG needs to be given every time.
Thank you, Dr. Kumar, for sharing your thoughtful responses for and your expertise today. I'm sure our audience must have gotten a deeper understanding of GBS.
Thank you so much. Appreciate it.